Okie doke. I'm just going to hop over to Facebook and ensure that we are indeed broadcasting first. We're fortunate that usually people are waiting right outside the room, ready to go on the top of the hour. All right. There we go. Okay, folks, let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNEX program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer by trade. I've been working with CCF for over 10 years now, about 12 years, maybe more. Time keeps on going. That's what it does. And in that 10 plus years, we've created all kinds of video content, live video series like the one you'll watch today, patient-centric documentaries. By the way, I'm traveling this weekend to create our next patient story in Northern California. Treatment-based videos, conference videos, hundreds, maybe thousands of videos in over 10 years, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, if you're new to this journey or new to the show, I want to say welcome. And the one thing that I have undoubtedly learned while working with this community in 10 years is it is extremely supportive. So you can see people chiming in the comments saying hello, where they're signing on from. If you're new, I encourage you to do the same thing. Embrace this community. It will embrace you back. It is very, very powerful, very, very supportive. The relationships between the specialists and guests, like our guest today, and the patients and the caregivers and the support group leaders is really something else. It's very impressive. So absolutely reach out to people and they will help you in this journey as well. So let us know where you're signing on from. I love to see how far the programs reach. So we are now, and have been for a while, partnered with LACNETS, which is an amazing relationship, and we're doing lots of great work together. One of the primary things is the support line that we have created, which you can visit at lacnets.org/support line. And that's for anybody affected by neuroendocrine tumors. So anybody needing support, patients, caregivers, etc., can fill out a questionnaire there, have any follow-up questions that you might have after today's show, and we'll try to get you those answers. Now, before we move on, we always want to thank our sponsors, Ipsen Biopharmaceuticals, because we couldn't do the show without their support. And we do have this disclaimer from them that we like to say at the top of the program, that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF or LACNETS don't necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. So, audience members should not rely solely on the opinions or information expressed by the guest presenter, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. I always start to run out of breath towards the end of that, but the real takeaway there is we don't know your specific case. So we're going to give you some general advice and hopefully answer some of your questions. Take those answers and that advice back to your home team, which does know your unique case, and they will, with you, make the best plan and path forward for you. Each case of this disease is unique, so each plan and path forward is as well. Go ahead and start sending in your questions, and we will get to them soon. But I'm excited today to welcome back to the show for the first time in 3 years, Dr. Hagen Kennecke. Dr. Kennecke, how are you?
Good morning, good afternoon. Real pleasure to be back on again. And I just love what CCF has done over the years. And so pleased to hear that they're working with LACNETS now. I think we're, this community is defined by collaboration and sharing and strength in numbers. So while it's really great to have individual groups, I think it's great that we've got some national collaborations going on. So I'm so happy to be part of it.
Absolutely. And that goes back to what I was saying earlier about the strength of this community. I totally agree with you in terms of the collaborative nature of it. And this is a collaboration we're really excited about as well and has already produced some great things. Now, we were talking earlier before we went live, and I know that you're at a new location now than you were then in 2021, I believe. But for those who may not be familiar with your work, tell us about what you do, where you do it, and the role you fill in this net community.
Absolutely. So I've been treating nets for many years, and I'm at the Oregon Health Sciences University, OHSU, and it's been a place that I've collaborated with for quite some time with good friends and colleagues, including Eric Mitra, Rod Pommier, and Will Pena. And actually, just 2 years ago, we did a NANETS conference that we co-sponsored with OHSU and Providence, where I recently worked. And so feels kind of like coming home. So I'm a medical oncologist, really involved in the systemic treatments, but also the navigation uh, for patients with NETs, and because that's an incredibly important um, kind of part of the treatment, right? Deciding what to do when and where, and it's very much a kind of a thinking specialty, and and problem solving, and I
Mhm.
love those two things, and finding solutions. So that's kind of my role in this.
Got it. Yeah, I think we will get a lot of questions, as we often do, about what to do, when and where, as you say.
Mhm.
Absolutely. And shout out to everybody you mentioned there, your colleagues. We had Dr. Pena on recently, and I'm certainly very familiar and know Dr. Mitra, who's been on the show a few times, worked with Dr. Pommier as well. So it's such a great institution that you have there. I'm sure you're glad to be there. Also, thank you for joining us. Dr. Kennecke is at home today, so he's carving out time for us, even when he's supposed to be probably relaxing. So we appreciate you for that. So everybody, before we get started, go ahead and start sending in your questions. Just a few rules of engagement, so to speak, best practices to help us do our job better, which is, of course, to help you. It's very hard to field in this format, at least, super lengthy, super dense questions. So try to ask, if you can, in short, generic chunks. There is no limit to how many questions you can ask, so you can always chime back in or have follow-up questions, but it's just a little easier for me to see in the comments there so that we can field them. And if Dr. Kennecke needs a little bit more information, he'll ask for it. Also, if anyone that you know, I see we have a few people joining us from YouTube. That community is growing, which is great. Most of the people still on Facebook. If there's anybody that you don't see in the comments section yet that should be here, go ahead and tag them and let them know that the show is going on. And in the meantime, we will start asking and answering some of your questions. So, Dr. Kennecke, I'll start with one myself. And I ask this often because I've worked at least tangentially with, in the net space for 10 plus years. I've seen the activity and the evolution of treatments and diagnostic tools, et cetera, et cetera. And there is obviously a flurry of activity that's been happening in the past few years. What areas are you most excited about in terms of things that are being developed currently or that are in that flurry of activity that I alluded to, and things that are hopefully helping you do your job better?
Yeah. So lots going on for sure, and I think there's a wide spectrum in this cancer, isn't there? And
Yeah.
one of our key goals is still understanding and defining these tumors and patients that have them and why they get them better. Um, I think we've seen some recent data about optimal treatment of these small pancreatic neuroendocrine tumors and when to do surgery and when to monitor. We just completed a study with the Population US-wide database looking at appropriateness of surgery versus ablation versus just following patients with the sub-centimeter PNETs that are actually remarkably common. And one thing that we did notice, we submitted this to NANET, so stay tuned for the data in November of this year. But one thing we did notice is that there was a dramatic increase in the number of patients diagnosed with small sub-centimeter PNETs over the past 12 years. So the study went from 2010 to 2021. And so that kind of supports our experience, right? That we're seeing these more and more. And the other thing that we found is that while it used to be much more common, 90% of people used to get surgery for these small peanuts, now it's down to 50%. So
Wow.
so this is just an example of uh, areas of interest where we're trying to understand how best to manage um, uh, this cancer. The other exciting thing is, again, for the peanuts is, adjuvant treatment. We have zero data for like prevention, if you will. So um, after definitive surgery is done, what do we do? And as we know, we see, many patients that have had successful surgery, but there might be a chance of it coming back, and everyone wants to know, what do I do now? So we are doing the study for PNETs, adjuvant chemotherapy with CAP-TEM. So that's exciting stuff, because if that one is positive and the study is accruing well, and I've put a number of patients on it, then that's really going to be a game changer. In terms of the setting where we still have cancer in the body that we can't remove immediately. Obviously, there's a lot of work there, and we are excited to hear that the Raise Bio alpha emitter second retreatment study is now going again. They were closed for quite some time in the sense that they didn't have drug, but they now have drug, and we can offer the alpha emitter second line retreatment trial. And I just put a patient on here at OHSU. So just get that word out there that where things are up and running again from that point of view for treatment on trial. Of course, we don't have the alpha emitters approved yet, and so in the meantime, we're doing a lot of retreatment off trial, and that has become much more of a standard. And at OHSU, we standardly do what's called dosimetry to measure the safety of the retreatment activity, and that's really kind of makes the treatment much safer. In terms of other things that I'm excited about is, we got the data on cabozantinib. We need to embrace this more. We got an update about it at ESMO,
Mhm.
a really definitive look at the quality of life, and there was quality of life, and the duration of treatment, and so what I see next is us learning how to incorporate that drug into um, another option for treatment. And I think we're probably not as comfortable with it as we could be. And we know that there's a lot of ways to dose the drug to be make it more tolerable, and that it probably has quite a large dosing window in terms of we don't always need to do the full 60 milligrams. So lots of details and lots more data coming there. But I did want to call out that treatment option in as an example of new treatments.
Absolutely. I appreciate that. And folks, we'll try our best on the back end to add any information, references, etc., that Dr. Kennecke mentions in the comments section too, so that you can easily navigate to those, to more information on those references. Dr. Kennecke, lots of questions already coming in, so I'm going to pivot to audience questions. First one comes in from Colleen. Colleen says, I have a well-differentiated neuroendocrine neoplasm, grade 1, diagnosed on gastric biopsy. The CT chest and pelvis does not show a primary site. So, what should I ask my oncologist?
So the gastric nets are definitely one of the better prognosis diagnosis. Having said that, we often see that they can occur in more than one area of the stomach. So follow up and rebiopsy is critical. I don't know whether the caller has had a definitive surgery or was just on a biopsy. If it's just on a biopsy, make sure you get a follow up um, a follow up endoscopy and um, and and do and like there's a whole bunch of detail here about do you
Right.
need surgery, and I think that would be beyond the scope of my answer. But the other thing that comes to mind is whenever we have a cancer, we want to have good staging, and part of good staging is a dotatate PET scan, isn't it, for neuroendocrine tumors? So I would suggest that if that hasn't been done already, then to suggest to do that, to have that done. One word of caution there: the stomach can light up quite a bit on these dotatate PET scans, even if there isn't cancer there. So uh, you have to be cautious in the interpretation of that scan.
Got it.
Hope that helps.
Yeah, thanks, Colleen. I hope that does help. Let me know if you have any other questions, please. Next one coming from Donald. Donald says, after living with small bowel nets for 5 years, a recent scan showed carcinomatosis in the mid abdomen. Any suggestions for treatment, or I would expand that to any suggestions at all?
So the yes, I'm sorry to hear that about the recurrence. We always want to make sure that it really is a recurrence. And again, we rely on the dotatate imaging to confirm it. And if there's any doubt, to do a biopsy. If indeed, that is the case, that the tumor has come back, we know that the nets can come back anytime within 10 years from the initial surgery. So 5 years after initial surgery is kind of in along the timeline of risk. Uh, the first question is surgery, and that is really where it's super important to get a opinion from a, a center with a lot of surgical expertise, because peritoneal disease is difficult to resect. But if that is the only site of disease, then it's better to do it earlier rather than later if the surgeon believes that they can remove it. So resection slash debulking, it should definitely be considered after all the staging and diagnosis is confirmed. And that has to be done within a multidisciplinary tumor board at a experienced net center.
Got it. Thanks, Donald. Hopefully that helps. Again, let me know if you have any more questions. From Lisa. Lisa says, if lanreotide shots don't seem to be working, new sites after 6 months post-op, do you think PRRT is the next best option?
So again, lots of caveats here, but we are using PRRT much earlier than we used to. And that has been supported by the NETTER-2 results, and which have recently been updated as ESMO, which really confirmed high response rates in PNETs and GI nets for in this case higher G2 and G3 tumors. So if there is evidence of progression, then you really should look for another treatment option, and PRRT is certainly an important treatment that in my practice, I generally incorporate earlier rather than later.
Got it. Understood. And for those who might not be familiar in the audience, could you explain what ESMO is that you've referenced a couple of
Oh,
times?
right.
That's okay. I know what it is, but just in
Right.
case someone just
Yes.
joining.
So it's, the acronym medicine is full of acronyms
Definitely.
and full of meetings, and it's the European Society of Medical Oncology, and they, much like ASCO or it's one of the international meetings where very important data is updated. So there was just a meeting in it's actually happening. I saw the slides. The meeting actually hasn't happened yet. It's mid-September,
Okay.
but I was the abstracts have
You
been
got an early screening.
right, right,
Early access
right.
pass. Gotcha. Yeah, I just want everybody to know, like, the events that are going on out there. Okay, moving on. Sasheen says, after primary resection and liver debulking, would stopping long-acting octreotide in favor of short-acting for CS carcinoid syndrome symptoms only be a valid choice if sandostatin proves to be an ineffective cytostatic? Ineffective.
Right. That's right. So, I think you've had some really key therapy with the surgical treatment, and the value of adding somatostatin analog, either short acting or long acting, if the tumor has previously grown on it, is really unknown. And there's actually a trial that is ongoing. It's a Australasian and Canadian trial called Stop Nets, where in a slightly different setting, patients are randomized to continuing versus discontinuing somatostatin analogs if they have no carcinoid syndrome and their tumor has previously grown on the treatment. So I think the fact that there's a trial like that just demonstrates genuine uncertainty about the value of this treatment. So in your situation, I would suggest that while it's not unreasonable to continue a somatostatin analog, so octreotide LAR or lanreotide, um, we don't know which one's better. I don't know whether I would say do short acting because that is much more inconvenient and is not known to be as good. I mean, the short acting is really, the half life is very brief, right? It's measured in 2 or 3 hours. And so, from a tumor control perspective, that's not ideal. We use it more from a symptom control perspective. Whereas the long acting, you've got a constant dose of drug over many, many months. And that is much more generally much more a preferred approach when it comes to disease control.
Got it. Thanks for your question, Sasheen. A couple of good, not generic, but kind of fundamental questions coming up. Lynn says, every physician, myself and my family have never heard of NETs. That's true, she says. The question is, are medical schools starting to give more attention to NETs? Because my family and I are actually having to educate the doctors, which is not unique to Lynn's situation here. And I know that we are seeing, I believe, from what I've been told from another guest, that we are seeing a rise in cases. I don't know if that's because we're diagnosing them more effectively or whatever, but is the knowledge of NETs growing is kind of the fundamental question.
I do believe it is. I think nets are increasing in frequency and the awareness is increasing and our ability to diagnose it is getting better. And that's why we still have so much work left to do, including, CCF and LAC nets to increase the awareness of this diagnosis. If you don't have a doctor or a provider that is comfortable with the treatment of this condition, in maybe I would just respectively ask them to, send you to someone who does, and nobody is would begrudge you for doing that because everyone really wants to treat according to the best practice, and if they don't know what that is, then they should refer you on to somebody else.
Yeah, and I mean that's part of what we try to do here on the show is not everybody has access to specialty centers, even though we do try to guide them to those places that really know this disease. But we try to fill in those gaps sometimes because I hear comments like this often. Catherine says, as a medical oncologist, what are some best practices for your patients to be doing to have the best overall care over time? That's a big question, but I think it's important.
Yeah, look, I think first of all, take care of yourself, right? Exercise, a good diet, and are really important. And if you have any triggers that you can identify that cause symptoms, avoid them. In terms of the medical care, you really it's super key to be treated by someone and a group that is familiar and has experience with the full spectrum of treatments, right? And that includes the surgery, and that includes the PRT, and that includes the medical management, and also and includes the imaging. And because these are hard to see tumors, and I've seen so many situations where a conventional CAT scan is done and there's no tumor seen. And then we do a CAT scan as well, but we do the triphasic with delayed phase images, and there's clearly and numerous presence of disease, and that's particularly in the liver. So if you don't know what you're looking for, you're not going to find it, right? So the imaging and the staff and the whole team is key. And I think obviously regular follow up is important. We try not to be too aggressive if in terms of intensity of follow up, and most of my patients appreciate that. If we have experience that the disease is really not progressing, then we can decrease the frequency of imaging. Um, and I try not to do too many blood tests that haven't been shown to really influence management. I love, novel assays like the NET test, and well, I'll do them if we need them. But there's the two ends of the spectrum, right? Making sure you do everything you can, and then there's also making sure you don't overtreat in a way that has detriments to your quality of life. So again, that's all about the team and getting good advice.
Got it. Going back to the previous question, Lynn did chime in and and say, I do see a net specialist, but her question was meant to be, are medical schools giving more time and teaching to nets, as so many net cases are undiagnosed for many years, as we know. I'm not sure if you can speak to that at all, but she just wanted to clarify that it was more about are they teaching more about it in schools, in medical school?
I mean, they are for sure not as much at that for the diagnostic point of view. It is kind of considered a weird and wonderful, and in medicine we do like weird and wonderful. So there is that knowledge about the disease, but then how to diagnose it, that's where the limitations are, and
Mm,
that's where I would continue. We still need to rely on the specialists to be able to find the tumor. I
yeah.
think we're going to continue to see a knowledge gap there.
Folks, if you joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program. We are here today with Dr. Hagen Kennecke, and we are just about halfway through, so it's moving along quickly as it often does. So, great questions so far. Keep sending them in, and we will try to get to them with the remaining 30 minutes. Next one comes in from Robin. Robin says, is there a study for reoccurrence of high-grade, non-functional, poorly differentiated stage 3 tumors, primarily in the anorectal junction? So, specific question, but is there a study for the recurrence of those, perhaps, or something similar?
Right. So it sounds like the caller may have been diagnosed with a rectosigmoid tumor that has been removed. It sounds like it's stage 3,
Hmm.
and the question is, what do we do? So the neuroendocrine carcinomas are separate from the neuroendocrine tumors, aren't they? And the neuroendocrine carcinomas, there's various approaches to their classification, but they are included in the adenocarcinomas of the colon and rectum. So if there is a diagnosis of a stage 3 resected colorectal tumor, then if it is a neuroendocrine carcinoma, so higher grade, not a NET, but a carcinoma, then we would generally consider the treatment with adjuvant, so preventive treatment of chemotherapy with FOLFOX or KBOX. So I would definitely suggest a medical oncology opinion for that.
Got it. Thank you, Robin. From Jim says, are there any immunotherapy treatments for carcinoid metastases that show promise?
Yes, that's an area of hope for us. For the well-differentiated tumors, we have not seen consistent benefit from the immunotherapy agents. There's ongoing trials. There's new immunotherapy agents. There's the LAG-3 agents. There's bispecific therapies. The LAG-3s and the bispecifics are starting to be tested in neuroendocrine tumors and all other tumors as well. So the door isn't closed on those treatments, but conventionally for well-differentiated neuroendocrine tumors, we have not seen a significant benefit from these agents. If the tumor is well differentiated, but it's behaving quite aggressively, the growth is rapid, then we do have some studies of specifically ipi-nivo, so a combination of immunotherapy, where we have seen some benefit. If the tumor is poorly differentiated or endocrine carcinoma, then we do have some good data that there's a fairly good response rate with ipi-nivo, with the according to the DART results. So that is definitely a treatment options for the higher grade tumors.
Got it. Thanks, Jim. Hopefully that helps. Again, let me know if you have any more questions. Still got plenty of time. Anna says, why is it questionable on the stomach with a dotatate PET scan when the scan is designed to only light up if cancer is present? It's designed to light up only the cancer from my research. So if the stomach is lit up, what else can it be if not cancer?
Yeah, no, absolutely. I mean, the way the scan works is it's a protein, is basically a somatostatin protein that binds to the somatostatin receptor. And although those somatostatin receptors are expressed in a much higher frequency in tumors, that's a normal receptor that we see on some normal tissues in the body. And that's what you're seeing on the scan. So particularly the GI tract has naturally occurring somatostatin receptors that the dye will bind to, essentially. So it's all about, accounting for that and knowing what the baseline background uptake is, and then comparing that background to what you're seeing in the stomach. So you're right. It is a little bit puzzling why those showed up, but we do see that in other parts of the body. For example, we always see the pituitary gland light up. There's no tumor there. We often see parts of the pancreas lighting up. There's no tumor there. So the stomach is a little bit, you can get a little bit of false positive there. But the good thing is we have the endoscopy that we can rely on to look at the stomach. And then if there's any abnormalities, they should be biopsied. And that's probably a much better understanding of what's going on in terms of tumor in the stomach.
Got it. Thank you. And thank you for your question, Anna. Referring back to something you said earlier, Dorothy asks, what did you mean about CT with delay? Is that the same as contrast?
That's right. That is a contrast CT, and it is also called a triphasic, and some people call it with or without. There's different names I've seen, but essentially it does still need contrast, but you're looking at it before contrast, during contrast, and then in a delayed phase after contrast.
That's the triphasic.
Right.
Yeah, got it. Someone else asked about that too. So, Maria, hopefully that answered your question as well. 2 for 1. Jim says, very informative show. Great to hear, Jim. A prior comment from you, Dr. Kennecke, you had mentioned triggers and symptoms.
Yeah.
And Jim's question is, what are some common triggers, if you don't mind?
So the triggers I was referring to was for people who have carcinoid syndrome.
Mm-hmm.
So pain, symptoms of pain, flushing, cramping. And sometimes those can be induced by certain foods, emotions, and some of those foods include caffeine, alcohol, certain types of food, perhaps high fiber. So to kind of be aware of what causes the carcinoid syndrome, and I, I encourage patients to develop a diary if to kind of track if they have a lot of symptoms. I wouldn't suggest doing it if you don't have symptoms. This is more for a strategy to manage symptoms that are ongoing.
Got it. Thank you. I'm jumping ahead a little bit, but Lori, this is not a question yet for you, I don't think, Dr. Kennecke, but Lori has a question. What about the lungs? Lori, could you just be a little bit more specific for me? And then I'll get to your question in just a moment. From Sasheen, our friend Sasheen again, is it typical for a net doctor to never perform a physical exam? Can all the information that they need be gleaned from test and symptom reporting?
Look, a physical exam remains an important part of an assessment. It includes a good observation of the patient. I often look at my patients closely while I'm talking to them to look for signs of flushing and or maybe diaphoresis. I will say, a physical exam is a little bit crude in the era of high technology scans. There's not much on a physical exam that we don't see on the CT scan, but it is absolutely a key part of an assessment. Particularly up in the neck, we don't. The CAT scan wouldn't get those areas. Listening to the lungs and feeling the abdomen, and for any abnormalities. The abdominal exam is important because, particularly for patients that have symptoms, we can kind of localize where the pain is coming from. We can try to reproduce the pain, and or look for distension, which might indicate that there's that there's peritoneal abnormalities, so and ascites and fluid. So those are all very important things to check for, even if you have good imaging.
Got it. Thank you. Excuse me. From Bernard, can net mets in the liver be mistaken for hemangioma in CT scan and MRI?
Generally, those should not be difficult to differentiate. We once in a while we're still puzzled. I was just on a tumor board this morning where we were certain there was a tumor, and then on subsequent imaging we weren't so sure, and that was on an MRI. So hemangiomas are generally they're fluid collections, aren't they? And so they have a much different characteristics, and they're homogeneous on imaging as opposed to vascular. So the short answer is generally we should be able to differentiate them, and if there is a concern that they may be hemangiomas, then they should not be biopsied because that can result in a bleed.
Got it. Thanks, Bernard. Good to see you, my friend. Next question from Maike. Let me know if I'm pronouncing that correctly. And looks like I don't believe I've seen your name here before. So if it's your first time, welcome. The question is, if you use lanreotide for tumor control only, so without carcinoid symptoms, and you are not able to inject at the 4 week interval, would you then advise to inject the couple of days before or after that 4 week interval?
Generally, we do have some discretion when it comes to interval of treatment. We know the half-life of these drugs is long, and even if you inject a little earlier or later, you will not compromise the efficacy because the dose that you're treating at is higher than what is needed to achieve therapy. So I think either option would be reasonable. I would say that if there is the presence of a lot of symptoms, for example, of carcinoid that are present and those symptoms worsen towards the end of the injection, then you would want to do the injection earlier rather than 3 days later, for example, than the recommended. But otherwise, I would suggest there's a choice.
Okay, got it. Thank you. Thank you. From Lori, who had asked about the lungs earlier, Lori says, I had a VAT in the lung and was told that I'm cured. But 6 years later, there's nets all over my body. I would appreciate Dr. Kennecke talking about the lungs also. Again, that's still pretty vague, pretty big. Anything you want to say or ask about that, Dr. Kennecke?
So, I mean, this is really important. The lung nets are not as common, and they're sometimes, in terms of a management perspective, they're managed by net specialists that also manage the GI nets, and sometimes they're managed by lung specialists. So we see. So you do need to have a team that is experienced in nets because the lung nets are nets, of course. And we need to make sure that the knowledge base for treatment is there for the team. The lung nets have, the classification has recently been updated. So diagnosis, again, is super key. And it's really been clarified about the typical carcinoids and then the atypical carcinoids of the lung, which have vastly different treatment and prognosis. So I would make sure to go back to that VAT that was done 6 years ago and do a pathology review. Make sure that to have a double check of what that diagnosis was, and because that may influence your treatment going forward. Um, if your tumor initially was a carcinoid tumor, then so a typical net of the lung, then those a lot of those treatments are very similar to the GI nets. If it was an atypical carcinoid, there is a number of other treatment options that are relevant. So that would be my initial focus, is to focus on the diagnosis and then make sure you have a team that a lung team or a net team that can manage those.
Got it. Thanks, Lisa. Let me know, or Lori rather, let me know if you do have other questions about that. I agree it's important. Shane says, shortly after debulking surgery, tumors grew notably. However, it was decided to wait 4 more months before changing treatment. Surprisingly, the 4 month follow up showed complete stability. Any idea what might explain this pleasant surprise?
That's good news, and I think I would definitely accept that. If you were just recently had surgery, there can still be some edema that maybe that can appear like there's a progressive net, and that is no longer the case. Um, Short interval imaging in 4 months would be my recommendation if there's no concern that there's growth.
All right. Yeah. Good news, Shane. Glad to hear that. Let me know if you have any other questions. From Belinda, if METs are located on the spine, can EBRT be used to treat the tumor?
Yes, that is a good treatment for them. We bone mets, including mets on the spine, are seen in about 40% of patients with more advanced tumors. So it is not uncommon. One unique characteristic of the NET tumors that go to the bone is that we very rarely see any complications from them, including pain or fracture. However, in the cases that we do, we should treat them aggressively, and SBRT is a good treatment.
Got it. Thanks, Belinda. And by the way, folks, I see a couple people being appreciative for the comments on lung nets, and just wanted to call attention to the link in the comments that LACNets just posted about their lung net resources, and also mentioned that their December webinar will focus on lung nets. So more information you can get there as well. About just a little more than 10 minutes, folks. Let's keep it moving. Diane says, I have carcinoid syndrome and I have been taking 1 ammonium and 2 pepto daily, and this helps tremendously, but I'm concerned that it's masking my carcinoid symptoms. So the question is, can I stay on this regimen long term? I have no other symptoms at the moment.
Well, I'm not familiar with what are the medications? Ammonium and
2 pepto
okay.
daily.
Well, certainly the pepto can help with diarrhea, but I think, yeah, I mean, we really think about carcinoid. There's two goals here, right? Number one is to manage the symptoms, and there are different ways to do that. I mean, we conventionally rely on the lanreotide or triotide, but if those don't are not effective, then you continue those. But it's okay to add other medications as long as they're safe. Telitristat is a medication, Zermello, for severe diarrhea, but other medications are appropriate to be used, and I wouldn't be concerned about masking symptoms. I mean, we need to manage these symptoms, don't we? The other objective, of course, is managing the cancer, any cancer that there's in the body, but we use the imaging and to imaging to monitor that.
Got it. Yes, Asheen, I agree with you. I think Diane, I think she meant Imodium, the anti-diarrhea medicine. It just maybe it might have been voice text. It said ammonium, but yeah. Anyways, just to clarify.
Yes, no, Imodium, totally appropriate. Totally appropriate. Yeah.
Yeah. I thought that's what she meant. Thanks, Asheen. I agree.
Okay. I'm relieved.
No, it's okay. I mean, it's spelled out as that, but yeah, that happens to me often, and sometimes on the show where we have to kind of figure it out. Okay, Shane says, for well differentiated nets, how often do you get genomic testing done? Does it ever change the treatment course?
Great question. I'm a big fan of genomics. For PNETs, the answer is I would always do it, and because they are genomically variable. For high-grade nets, I would definitely recommend it. For the G1, low G2s that are behaving well, or if you're trying to use it as a way to plan therapy, I have not seen that genomic testing being helpful in terms of management. If there is a diagnostic concern, in other words, you're not really sure where this cancer falls, like we look at it under the microscope and it looks like, oh, we're not sure if it's high grade or low grade or neuroendocrine carcinoma or neuroendocrine tumor, then in next generation sequencing, the genomic testing can be super helpful. So those are the situations where I would do it in.
Got it. Another question, what's the difference between an MEN1 germline mutation versus MEN1 somatic mutation in genomic testing for PNETs?
Right. So that's a great example of the PNETs, and that they do have a lot of genomic variants, abnormalities. And MEN1 is a very common one. And that is the fact that is there supports a diagnosis of PNETs. It does not at this time affect our management, and it definitely does not mean that you have a germline MEN mutation. I know I see some colleagues, they're concerned about, oh, I have to do germline testing for MEN1, but that is generally not recommended reflexively if there's no other concerns about MEN1 in the patient.
Got it. And just to back it up a little bit, Eileen says, what exactly is genomic testing?
So genomic is testing, yeah, good point. It is a super broad term, and basically we're looking at the genetic material. And there's essentially two big ways. There's a number of different ways of doing it. You look at the genetic material of the cancer, and then which is the somatic, and then the genetic material of the of your normal cells. That's called germline, and you can do that from a blood test or saliva test. There's other ways of testing it. For example, circulating tumor uh, testing. So you look for the genomic assays in the blood, but we don't use those very much in NETs.
Got it. Thank you, Eileen. From Carly, why do some CTs use oral plus IV contrast versus others that just used IV?
Oh, yes, the oral contrast question. So the IV, you need the IV. The oral, there is variability, and there are. And I generally am very supportive if patients don't want the oral. The oral is valuable when you're looking for peritoneal abnormalities or perhaps even some abnormalities in the bowel. But they are generally for oncology follow-ups, imagings, don't add that much. Having said that, what you'll find is oral contrast is like a standard, kind of a reflex standard at many institutions for everything. They kind of treat everyone the same way, whether or not they have cancer or not. And so it's kind of hard sometimes to not to not convince them that you don't need the oral. So um, if it causes a lot of side effects, there's some role to be able to avoid it, but you'll have to talk to your radiology team to make sure they're okay with that.
Got it. Thanks, Carly. Lisa says, I was told I have grade 1 well differentiated nets. So why is it showing up in new nodes so quickly? Is it possible that it is in fact not grade 1? And how is that even determined?
Right. We we do see that, we see one thing on them under the microscope, and then we see something else that's happening. And of course, the most important thing is like what's happening. I would always have a very low threshold for a repeat biopsy. Sometimes if there's nodes, that is not always that easy. However, um, um, we assess grade by looking at specific characteristics, essentially what the tumor looks like under the microscope and the Chi67 or mitotic counts. So in other words, how rapidly the tumor is growing. However, that's just at a point of time whenever the tumor tissue is removed, and then you look at it, but you don't know, the tumors can change, right? They rarely change from, an N1 to, sorry, a G1 to, a G3. But, they can be changes. Uh, Sometimes we see that the nodes appear, and we don't see we see that they can remain stable, or the tumor can remain in the nodes for quite some time. So I think it still remains to be seen how important this nodal progression is in your case.
Another question about mutations in PNETs. Shane says, does DAX, DAXX, and ARTX mutations in PNETs hold any merit at this point in time?
Those mutations are also very characteristics of PNETs, and they do not generally affect either prognosis or treatment.
Got it. Thanks, Shane. Dr. Kennecke, earlier in the program, I asked you to elaborate on some of the things the activity that has been happening lately that you're excited about. Kind of the flip side of that coin, I'm curious if you forecast into the next, 5 years, we'll say, what are the areas where you would like to see more activity in terms of being able to do your job more effectively?
You know, I, I think we need to, prevent recurrence. I think that's the big emphasis,
Mm-hmm.
and uh, studies in those areas, studies of preventive therapy with lanreotide after surgery. We need to do those because that's what it's all about, right? Is not having these tumors. If I think we've seen for patients where we have an established diagnosis of advanced disease, understanding better the role of surgery, potentially doing PRT first and then doing surgery, and then the whole sequencing question of getting more people to surgery by using these treatments that can control and shrink the tumor, and then following that up with surgery. We're doing some of that work at OHSU, and I I think that's the right direction because that's what we're doing in other tumors. So we're going to attack them from more than one way,
Yeah.
and would love to see more of that. And we talked a lot about genomics on today, and we need to get better at characterizing these tumors and doing it in a way that we can get results frequently
Yeah.
and often to understand if the tumor is changing, because these tumors do change. And and so we're not quite there yet. We tried with the circulating tumor DNA, and we have to be careful with that one because we often don't see those tests coming positive. So we're just at a really high risk of missing stuff if we use that test. The NET test is promising, but it needs more work. But I I would love to see more work on molecular testing of these cancers so we can better understand them, both at the time of diagnosis and then in real time as we're offering treatments.
Got it. And last question for today. If someone was recently diagnosed this week, let's say, and they don't know what this disease is, they haven't heard of it, they're confused, they're scared, what would your advice be to a very newly diagnosed patient at the very beginning of this journey?
Look, you know, I think my advice is, get lots of information and proceed, diligently and with good guidance. And the one thing with this cancer is we generally don't see that it's rapidly progressive, so we do have time to get all the information and do the right thing.
Absolutely. And folks, that is what we aim to do here on the show, is to continue offering some of that information to help you along that journey. We hope today's show has done that again for you. Dr. Kennecke, thank you so much for being back on the show.
My pleasure. Great to see everyone. I saw the chats coming in. I really
Okay,
appreciate all
good.
the comments and all the questions.
Yeah, you had a lot of friends and fans in the audience. Ellen says, "Thank you, Rain. Dr. Kennecke is the best."
Yeah. Hi,
Uh,
Ellen. Yeah.
Yeah, lots of
Awesome.
people, lots of people. And thanks to you all at home as well. We hope this program answers some of your questions. Again, I'll reiterate, follow up with us if you have further questions. We'll be back in 2 weeks. And of course, you can reach out at lacnets.org/support line. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe.